Hello everyone, my name is Safwan Halaby. I'm a pediatric radiologist and Director of Imaging Informatics at Henry Ford Health System, Department of Radiology. I'm going to go over a few of the clinical initiatives that we use to reduce patient radiation exposure. My talk is split up into three sections: practice quality initiatives, including pediatric CT dose reduction, clinical decision support, we are one of the conveners of the Medicare imaging demonstration, and also a research project that used PQI and CDS, including the Nexus criteria in the emergency department. In 2006, our department reevaluated the use of CT in the pediatric patient population. We developed new protocols with our radiologist, our technologist, our physicist, and we wanted to get down to the lowest radiation exposure while maintaining diagnostic quality. In an effort to reduce the patient CT radiation dose, a standard age and weight-based protocol was developed to guide our technologists and interpreting radiologists when protocoling diagnostic examinations. New protocols were disseminated to the radiologist and technologist, and all CT orders were protocoled by a radiologist before performing or acquiring the imaging. Looking at the data, we looked at all of the emergency department CTs in the pediatric population, so 18 years and under. We had about 107 cases that we looked at in 2005 and approximately 96 that we looked at in 2007. Again, the protocols were changed in 2006, and we saw a significant decrease in the CTDI vol and the percentage of multiphasic studies. And you can see here we reduced the radiation index by about 26 to 30%, and then we reduced the number of multiphasic imaging studies by approximately 36%. The take-home points with this PQI project was to, again, ALARA as low as reasonably achievable, basically stating that lowest dose possible to maintain diagnostic quality, to child size the scan, to not overscan, so only scan when necessary and only in the indicated region of interest, and to only scan once. A lot of the multiphasic scanning that's done in the adult population does not really yield much benefit in the pediatric population. And also to be a team player, to work with physicists and technologists to reduce radiation dose and maintain diagnostic quality imaging. Now, going to our second phase is looking at clinical decision support. We were part of the Medicare imaging demonstration, which was a law that was put into place in 2008, and it was set up to collect data regarding the appropriateness of physician use of advanced diagnostic imaging services and to collect data regarding physician compliance with appropriateness criteria. The demonstration focused on advanced diagnostic imaging services that account for a large share of expenditures, have experienced a high rate of growth, and services for which clinical appropriateness criteria exist. So the statute included 11 targeted exams, including MRI, CT, and nuclear medicine studies. And these are the examinations that were included, so you're in everything from neurological studies to body studies, musculoskeletal, and cardiac. The goals of the Medicare imaging demonstration were to test whether the use of clinical decision support systems can improve quality of care, reduce unnecessary radiation exposure and utilization by promoting the appropriate ordering of advanced imaging services. Our medical group, as an incentive, would receive the feedback on the degree of appropriateness relative to the specified medical specialty society guidelines. And also, over time, they would be able to compare with their peers on their ordering habits and use of appropriateness guidelines. The conveners in this Medicare imaging demonstration included Henry Ford, Brigham and Women's Hospital in Boston, Maine Physician Group, and University of Wisconsin, including a radiology business manager, National Imaging Associates, NIA. The society guidelines were basically anything that was published from the major society guidelines, as you can see here, from many different areas of medicine and subspecialty. And this is an example of one of our order entry systems that we, again, customized and included clinical decision support based on the ACR appropriateness criteria. So the scenario is a 99-year-old male with osteoporosis and chronic back pain, which has not subsided with conservative therapy. A clinician would go in and order the examination, so the CT of the lumbar spine. They would then need to include, and this is where it's a little bit different, where we needed decision support information. So we have low back pain, And this led to the different scenarios within the appropriateness criteria or the clinical decision support, and saying, again, choosing low velocity trauma. These are the scores that the clinicians would see at the time of ordering those studies. So, this CT examination was an uncertain appropriateness. So it wasn't really the best study, and it wasn't inappropriate. But as you can see here, the clinician is able to choose a more appropriate study, which would be the MRI of the lumbar spine without contrast. And you can see here, if you decide to choose a study such as an inappropriate study such as MRI with contrast, the clinician would need to justify the exam. Some of the justifications include the physician doesn't agree with the guideline does not apply to the patient condition, and so on and so forth. Now, the important caveats to this study is that no pre-authorization is required for Medicare beneficiaries during the MID. The ordering pathway starts with the exam modality and body part, not the clinical scenario, and the appropriateness scores are not revealed to the ordering provider until the intervention period. So there was a 6-month lead up where we were not showing the scores, and then there was an intervention phase where we were showing the scores. What we did to improve usability is that we allowed for searchability of the appropriateness criteria. A lot of feedback we got was we can't find the right scenario, so we added search. And all of this is going to lead us toward a scenario where we can help societies by understanding the ordering habits and also guiding clinicians to the right examination and prioritizing the establishment of new guidelines that reflect the needs of the ordering provider and safety of the patient. Now, again, the data and research from the MID and the ACR web services that we utilize may help build the case to replace the pre-authorization process used by payers and RBMs with decision support systems integrated in computerized physician order entry. The last part of my talk was to discuss a research project being done by Dr. Griffith, who is a senior radiology resident. He did a 3-phase study to look at utilizing nexus criteria to identify patients that have low probability of cervical spine injury in whom imaging of the cervical spine was unnecessary. The assessment of the number of unnecessary cervical spine CT studies based on the proper application of established guidelines, and to determine the indications for ordering studies in the absence of guideline criteria. What was unique about this situation or this research was it was done in combination with the emergency department, which utilizes advanced imaging heavily. Now, the methods of this study was to look at all patients presenting to a level 1 trauma center for whom a screening cervical spine CT was ordered in the setting of blunt trauma. The clinicians, prior to ordering the advanced study, would go through this nexus criteria on paper and would basically give a number score to what their thought was if this patient was a high suspicion, medium suspicion, or low suspicion for cervical spine injury. And the results, again, out of the 507 CT examinations, 1% of them were positive, 98% were negative, 5 of the studies were indeterminate, and out of that of the 502 studies without cervical spine injury, 81 that were imaged despite meeting all 5 nexus criteria for non-imaging. So as you can see here, again, is a graphical representation of those results, that 16% of those studies could have been avoided if there was an adherence to those nexus criteria. And the conclusions of this study was that a strict application of nexus criteria could potentially reduce the number of screening cervical spine CT scans in the setting of blunt trauma. This change would avoid a considerable amount of unnecessary radiation cost. Again, those were just a few of the initiatives at Henry Ford Health System. I'm going to turn it over to Dr. Mark Supanich, who is a clinical physicist, and we'll discuss some of the back-end radiation dose indices and quantification of patients.
Thank you. Yes, so I'll be talking about a couple of tools that we have used over the past several years to both track and monitor the radiation dose used for studies, and how the use of those tools has led to some interventions to optimize the radiation dose and to make sure we have continuous quality assurance going on for our protocols. So the first project I'm going to talk about is having to do with the ACR Dose Index Registry. We began here at Henry Ford to participate in the Dose Index Registry in 2012. And to participate in the Dose Index Registry, it requires anonymized submission of CT studies to the ACR's Triad server. But as part of that, what is required is a mapping of the CT orderable that was used and that was indicated for the study, a mapping of that orderable to a standardized nomenclature to facilitate comparison of the radiation doses used amongst different institutions. Just using the institution's nomenclature would lead to innumerable cases of confusion, as one institution may call it a CT head without, another may call it a CT brain without, and so on and so on. So a requirement is a mapping of the facility's orderables to the standardized nomenclature, which is the Radlex Playbook ID. And as indicated on this slide are instructions on how to access the Playbook ID. What we did at Henry Ford is we took a prospective, team-based approach to map our CT orderables ahead of time to the Radlex Playbook IDs so that those IDs could be included with the exams at the time of submission to the ACR. And it did not require us to, after the fact, go onto the ACR's website and map the exams there. We were able to do it ahead of time where we had all the information about the orderable, about the exam, and the indications. So we did that. And to do that, we first went to the Radlex Playbook site and downloaded the template for Excel, which then allows you to import your orderables and the descriptions into this exam template. What it then allows you to do is to map for each exam the values into the predicate fields. So that, for example, at the very top here, the exam is a CT lower extremity right without contrast. And to map that, you would first map the lower extremity into the body region. There would be no anatomic focus, but there would be a laterality of right and without contrast enhancement. Another example would be mapping a CT abdomen and pelvis to a CT body region abdomen, body region pelvis, and without contrast, and so on and so on. So we did this ahead of time and then sent this completed spreadsheet back to the Playbook team, and they either generated new Playbook IDs for exam combinations that hadn't existed before, or assigned already existing Playbook IDs to the mapped values. So then we received that, and those values were included with each study that was submitted to the Dose Index Registry, as shown up here at the top of this slide, with a RPID of 406 in the Performed Procedure Code Sequence Code. And so that was included with the studies, which really saved us a lot of time from having to go back after the fact and map these. An added benefit of this prospective mapping is that we were able to differentiate first between different studies, say a reduced dose or a standard dose study or a limited study. We had that information ahead of time as opposed to perhaps after the fact only having the study description, because after the fact you may only have the study description on which to do this retrospective mapping. So this self-mapping we felt was more accurate, and not only that, we'll be able to refine it in the future to add more granularity instead of just having a overreaching one for all CT abdomens and pelvis. We'll be able to add in multiphasic information in the future and just automatically have that populated. Another benefit is that this allowed us actually to build up a single spreadsheet which includes our orderables, the RPIDs for those orderables, and then also we included a mapping from the orderables to the master protocol, which allows us to easily visualize how from the ordering to the protocoling and then the specific RPID works, which is actually quite helpful for troubleshooting. As we get the Dose Index Registry reports back, it allows us in-depth investigation into anomalies because we know what protocol was associated with the RPID, and we can really delve into it that way. So here's an example here showing what the RPID is, the exam code, the description, and the protocol on the right. The first intervention I'd like to talk about here quickly was using a dose tracking software. And using it, we noted a difference in the DLP amongst different vendors for head CTs. And especially that the DLP for on the Philips scanner was significantly higher than that from some of the other scanners that we have. We identified first one reason was that the CTDI vol used for the scans on the Philips scanners was higher, but we also determined that there was more overscanning on the Philips systems than we were experiencing on some of the other systems. And we were able to see that in this plot shown here, where you can see that the average or the mean DLP for the Philips head CT, which is shown in the center, was 1550 milligray centimeters, where for the some of our GE scanners it was around 1075 milligray centimeters, and for the Siemens system we have it was around 1200 milligray centimeters. After an intervention where we actually lowered the CTDI vol setting for the Philips scanners, we were able to bring the mean DLP for that down to about 1290 milligray centimeters. So that's one thing we were able to do with some of the software that we have available at our institution to really do an intervention based on what we've seen. An additional intervention that we did after receiving our first dose index registry report, which showed that our mean abdomen doses were higher than the national average, and you can see that here on this plot on the left is what our abdomen pelvis CTDI vols were for the a Philips scanner with a mean of about 17 milligray over almost 2,000 patients over a certain time period. And so we saw that our dose levels were high for that compared to the national mean. And working with the abdominal division head, we incrementally adjusted the tube current modulation settings on the scanner and brought the mean CTDI vol down from about 17 milligray down to about 15 milligray, which is actually below the national median for the abdomen pelvises according to the dose index registry. One final thing I'd like to touch on briefly is that we do have a continuous quality assurance protocol going on to make sure that our CT protocols are being implemented correctly and aren't changing. And the way that we do that is we've developed an in-house tool that allows the technologist, if they see a CT value that is over a prescribed CTDI notification value for that protocol, to write in our PACS system, right-click off of an image to launch a tool that allows them to report that the CTDI vol for that study was greater than the CTDI notification value, and then an email is generated that goes directly to the CT supervisor and to the 2 CT physicists at our institution. So this allows us not only retrospective to do, after the fact retrospective quality assurance to make sure our protocols are optimized, but also really allows almost real-time monitoring to make sure that the CT protocols are optimized for dose and image quality. Thank you.